Well, Graham, we've talked about a lot of high-risk topics today, and I think it makes sense because of the volume for us to talk about wounds in the ED. And wound care claims, while they're low severity and they're usually resolved with low indemnity and expenses, they're high frequency enough that I think it makes sense for us to discuss it. Some of the allegations around wound care are related to infection, scarring, loss of function, failure to detect a deep structure damage, and failure to detect a foreign body. So I thought if we focused on foreign bodies, give the listeners some wound management tips and also some tips on documentation. So Graham, let me ask you, when should an ED physician be suspicious of the likelihood of a foreign body?
Well, it's a great question and a great topic. Obviously, managing wounds in the emergency department is our bread and butter. So you're right, it doesn't pop up on the severity list, but certainly on the frequency list. So I think that really boils down to the basics in terms of wound care. The first thing is a really good history and to elicit a mechanism of injury. If you're suspicious of a foreign body, fall on an outstretched hand, those type of things, a puncture wound, then you really need to go looking for the possibility of a retained foreign body. Puncture wounds, stab wounds, did they go through clothing, did they go through shoes, would all heighten your index of suspicion. I think wounds that are involving glass, debris, plastics, wood, again, would give you a high index of suspicion. And lastly, if the patient says that they feel something, even though you can't see it on your exam, you should take it to the next level and try and find that foreign body.
Okay. As an ED physician, when would you utilize a plain film when you suspect a foreign body?
Good question. Plain films are very helpful if the material is radio opaque. In other words, you can identify it on a plain film. So metallic foreign bodies, most glass is radio opaque, but it's very poor sensitivity for vegetative material like splinters, like wood, some plastics, and things like cactus spines.
Okay. And if you're not going to use a plain film, or you think a plain film isn't going to be adequate, what would the indications be for a CT scan?
Well, a CT scan will certainly give you more definition and will pick up structures that are deeper down as well as ones that may not be radio opaque. But I think the important thing is for things like soft tissue infections, if you were looking for air in the tissue space, if you were also suspicious of an abscess with a retained foreign body, CT scan will give you much more information.
Okay. So we've talked about plain films and we've talked about the applications for CT. Are there any other modalities that might help detect a foreign body?
I think ultrasound is really, a game changer in the way we practice emergency medicine, and I think ultrasound is fast, it's effective, it can do a rapid screen, it's useful for many different things, but also it's starting to be used more and more to take a preliminary look for foreign bodies. I guess what I would say is it's helpful if you see something, but if you don't see something on ultrasound, doesn't necessarily mean that it's not there. If you have a high index of suspicion, then you probably ought to move to something like CT, which will give you more definition.
Okay. All right, well, let's switch gears. We talked quite a bit about detecting foreign bodies. I know that there are some wounds that are real complicated, and being the age that I am, I remember the paint guns that were so popular back in the 80s. Can you talk to us a little bit about high-velocity wounds?
Yeah, I think two different things. One is high velocity, the other is high pressure. High velocity wounds, as in gunshot type of wounds, obviously in consideration. But the paint gun specifically, the problem with them is a very small entrance wound, but the possibility for lots of contamination in the deep tissue layers, which you may not see. So back to the original history is, what is the mechanism of injury? And if there is a point wound and somebody was working with a pressure gun, usually they're cleaning them and there's a discharge of the gun, and that propellant or paint or whatever it is dispersed into the tissues. Those wounds can be very complex, very difficult to treat, but the key thing to do is to recognize it.
Mm-hmm. Okay. What other tips can you provide for emergency department physicians and mid-level providers on wound care?
Well, again, most of it's about the basics and doing a thorough history, making sure that the patient is at not risk, for example, by having diabetes or some other underlying history. Prophylactic antibiotics is a big topic of controversy, and most low-risk wounds don't need antibiotics, but wounds that you should be suspicious and consider are things like human bite wounds, cat bites, which tend to be deep puncture wounds where it's very difficult to irrigate out out all the contaminants. So those are some high-risk wounds to consider for antibiotics. I think crush wounds and dirty wounds, those ones are also for consideration. Debridement is essential in wound care. Irrigation is essential in wound care. Making a decision about whether you should primarily close a wound or leaving it open, and informing the patient that there may be some scarring associated with it, but that those scars can always be revised. I think that the tendon status, a distal neurovascular exam, those things are absolutely paramount to document and to examine. And consideration, we've seen several claims that have come from wounds that have been in proximity to bone or to joint, where there may be an open fracture that's not detected, again, back to mechanism of injury, or a puncture wound that goes into joint. I've seen several of those cases. So high index of suspicion, good documentation, good exam. I think proper wound care in the emergency department is about the basics. It is about the history, inspection, it's about debridement, irrigation, and it's about making the decision whether to close the wound or not. It is something that is our bread and butter, so taking some of these tips into consideration will help us improve risk in treating these wounds in the emergency department.